In 2019, the FDA took an action it rarely takes. It issued a contraindication, not a warning, a contraindication, stating that patients who have experienced certain behaviors while taking this sleep medication must never take it again. Those behaviors include driving a car, preparing and eating food, having sex, all performed while asleep, all with no memory the next morning. Millions of people take this pill every night. Most have never heard that sentence. That medication is zolpidem, sold under the brand name Ambien. It belongs to a class called sedative hypnotics, medications designed to quiet the brain quickly enough to make sleep arrive. And it works. Within 15 to 30 minutes of taking it, most people feel the racing thoughts slow, the tension in the body release, the wakefulness give way. For someone who has been lying in the dark for hours, night after night, unable to stop their own mind, that relief feels like being rescued. But the FDA label for zolpidem contains language that most patients never see when the prescription is handed over at the pharmacy counter. It states that the medication is indicated for short-term treatment of insomnia. It states that treatment should be as short as possible. And it carries a boxed warning, placed at the very top of the prescribing document in a black border, about behaviors that happen while taking this medication. Behaviors the person taking it has no memory of the next morning. To understand why those behaviors happen, you need to understand what zolpidem does inside the brain. The brain has a primary calming system. It is built around a chemical called GABA, gamma-aminobutyric acid. GABA is the brain's brake pedal. When the nervous system is running too hot, too alert, too anxious, too stimulated to allow sleep, GABA hits the brakes. It reduces the electrical activity throughout the brain. It creates the conditions for sleep to begin. Zolpidem binds to the same receptors that GABA uses and amplifies the braking signal far beyond what the brain produces on its own. The result is fast and reliable. The brain activity drops, consciousness fades, sleep arrives. But the brain quieted by zolpidem is not simply asleep in the way natural sleep works. Natural sleep involves a progressive, organized quieting of different brain systems. Systems that govern movement, decision-making, memory, and behavior shutting down in a coordinated sequence. Zolpidem compresses this process. It quiets consciousness quickly, but it does not always fully shut down the systems that drive behavior and movement. The result is a brain that is no longer conscious, but is still capable of generating complex coordinated activity. Sleepwalking has long been associated with sedative hypnotic medications, but the FDA label for zolpidem documents something more alarming. Sleep driving, getting into a car, driving to locations, returning home with no memory of any of it, preparing and eating food, patients waking to discover empty wrappers and dishes they have no recollection of using, making phone calls, sending text messages, having full conversations while unconscious. In one category of reported cases, engaging in sexual activity with no memory of consent or occurrence. All of these documented in post-marketing reports, all performed while the person believed they were asleep, all leaving no trace in memory the following morning. A systematic review of 24 previous studies confirmed that the risk of these behaviors was not dependent on age, dose, or even a prior history of sleepwalking. People who had never sleepwalked once in their lives developed this behavior while taking zolpidem. The FDA's 2019 contraindication, the action stronger than any warning short of market removal, was issued because the consequences of these behaviors include serious injury, harm to others, and death. Not theoretical risk, documented outcomes in real patients. Have you or someone you know been taking this sleep pill for longer than a few weeks? What comes next is what most patients are never told before the first prescription is written. Beyond the behavioral risks, the long-term picture of zolpidem use raises several concerns the label documents directly. Memories. Zolpidem impairs the formation of new memories during the period following its ingestion. This is not simply about forgetting where the keys were left. It is about the brain's failure to consolidate information during what should be its primary memory consolidation period. Normal sleep, particularly the deeper stages, is when the brain transfers experiences from short-term to long-term storage. It is when learning is reinforced. When the events of the day are processed and filed, zolpidem-induced sleep does not replicate this function as effectively as natural sleep. Over months and years of use, the cumulative effect on memory and cognitive function is measurable. Research has found that long-term benzodiazepine receptor agonists, the class zolpidem belongs to, are associated with deficits in attention, verbal memory, and processing speed that outlast individual doses. For an older adult already concerned about cognitive aging, this is not an incidental concern. Next-day impairment. The FDA issued a specific additional warning that zolpidem levels can remain high enough in the bloodstream the following morning to impair driving performance, even when the person feels alert, rested, and competent to drive. Women eliminate zolpidem from the body at a slower rate than men. The FDA specifically recommended a lower starting dose for women because of this. And yet, the same 10 milligram prescription has been written for decades without systematic adjustment for elimination rate, body composition, or age. The person who takes zolpidem at 10 o'clock at night and drives their grandchildren to school at 7 the next morning may be doing so with clinically significant drug impairment they are completely unaware of. Dependence and rebound insomnia. The label warns that the risk of dependence increases with use beyond 10 nights. 10 nights. Most people taking zolpidem have been taking it for months, many for years, some for more than a decade. When zolpidem is stopped after extended use, a phenomenon called rebound insomnia reliably occurs. The sleeplessness that returns is often worse than the insomnia that led to the prescription in the first place. This is not coincidental. It is the brain compensating for the prolonged artificial suppression of its own calming system. The GABA receptors that were enhanced by the medication have downregulated, reduced their sensitivity in response to the chronic amplified signal. When the medication is removed, the brain's natural calming capacity is temporarily less than it was before treatment began. For many people, this is the moment they first realize that stopping is not straightforward, not because they are weak, not because they lack discipline, but because the brain has reorganized itself around the presence of the medication, and its absence creates the very problem the prescription was written to treat. None of this means zolpidem is never appropriate. For acute insomnia, grief, a medical procedure, a period of extreme situational stress, short-term use under medical supervision may provide exactly the relief that is needed. What it means is that the label says short-term for reasons that were documented, researched, and placed at the top of the prescribing information, and millions of people were never told what those reasons were. For sleep without medication, cognitive behavioral therapy for insomnia has been demonstrated in multiple controlled trials to outperform sleep medication over the long term. It addresses the underlying behavioral and cognitive patterns that perpetuate insomnia without producing dependence, rebound, or next-day impairment. Sleep restriction therapy, stimulus control, relaxation training. These are the tools that change the brain's relationship with sleep, rather than chemically suppressing the awareness of sleeplessness each night. For those who need pharmacological support during a transition, many doctors recommend a gradual taper of zolpidem rather than abrupt discontinuation, coordinated with behavioral work to give the brain time to rebuild its natural sleep capacity. And the questions worth bringing to the next appointment. How long was this medication originally intended to be taken? And has that timeline been revisited? What would a plan to gradually reduce and stop this medication look like? Are there non-medication approaches we have not yet fully tried? Is my cognitive function or morning alertness being affected in ways I may not be recognizing? These are the questions of someone who wants real rest and understands that the pill is not the only path to finding it, and that for some people, it may be making the path longer. Subscribe to Med Truths. Every week we read the label on the medications most people take without ever reading what is inside, so you know what to ask. Here is the truth about zolpidem. It quiets the brain quickly enough to make sleep arrive. For acute insomnia, that speed is sometimes exactly what is needed. But the brain that is quieted by zolpidem is not always fully at rest in the way natural sleep requires. It can move through a house, it can drive a car, It can act without consent or awareness. And the brain that adapts to this medication night after night adapts completely until the absence of the pill becomes the cause of the insomnia the pill was prescribed to prevent. That cycle is documented. The behavioral risks are in the boxed warning. The memory concerns, the next day impairment, the dependence potential, all of it is in the label. It has always been there. You just needed someone to read it out loud.